I'd like to send a thank you to the funders who support Cochrane Canada and systematic reviews done by the Cochrane Collaboration here in Canada. Thank you to CIHR for providing support. I'd like to send a special thank you to PAHO, the Pan American Health Organization. They provide support by giving us this software that allows us to offer these webinars for free to you. Luis Gabriel Cuervo, who works at PAHO, takes these webinars and turns them into recordings for us so that they're available online afterwards through YouTube. Thank you to Luis Gabriel for his support. Today's webinar is being presented by Dr. Yoon Loke, who's presenting on If Nothing Happens, Is Everything All Right? Assessing the Validity of Adverse Effects Data. Dr. Loke is a senior lecturer in clinical pharmacology at the University of East Anglia, and he's the co-convenor of the Cochrane Adverse Effects Methods Group. He has extensive experience in conducting systematic reviews of adverse effects, and he's the lead author of one of the chapters in the Cochrane Handbook. He also serves as the European editor for the British Journal of Clinical Pharmacology. His main research interest is on how systematic review methodology can be used to answer clinically relevant questions on the adverse effects of medications. And I'd like to turn it over to him for his presentation today. Thank you.
Thank you, Erin. Today's talk will feature on something that happens quite commonly when analyzing adverse effects, and that's when you find that no harm is reported, or there are no significant adverse events detected in the studies that you look at. So, one of the main questions that we have in assessing an intervention is, how does the benefit compare with the harm? And in most Cochrane reviews, the primary question is focused on, does it work? And often a detailed assessment of adverse effects is not made publicly available. However, there are a number of specific situations where safety issues crop up, and this is getting more commonplace because we use new drugs that have similar efficacy, but the newer intervention is claimed to have some a better mechanism. It's safer to use and it's less harmful as compared to the existing agent. So the new agent doesn't work any better, but it's claimed to be better tolerated by the patients, for example. Equally, we have lots of older interventions on the market that are being investigated in new groups of patients or different groups of patients which we haven't tested it for in the past. So there arise a number of very specific situations where we feel the need for more accurate adverse events data. One of the key situations is where we view the benefit-harm trade-off to be very narrow, so the benefit is quite close to the harm. For instance, there's a situation where the treatment appears to have clear benefits, but the patient is particularly susceptible to having a risk of adverse effects. So we all know that patients who've had a stroke clearly benefit from taking aspirin, but we know that some of these patients have a history of peptic ulcers and they have bleeding from the ulcers, or they may have started taking the aspirin and they develop bleeding from an ulcer. So in this group of patients, we would like to weigh up very thoroughly the benefit in preventing stroke, but what's the harm of the drug in causing ulcer bleeding in the patient? Equally, on the next item, we have situations where the intervention provides some benefit, but the patient doesn't experience the benefit straight away. However, delivery of the intervention may create immediate adverse effects. For instance, we give vaccines to prevent disease that may not arise for the next 10 or 20 years. But if the vaccine is harmful, you may experience the adverse effects right now, whereas the benefit is delayed. And similarly, treatments to help you stop smoking, you may not have any cardiovascular benefit for some time. Now, the third point I'd like to make is that there are a lot of interventions that are tested where the beneficial outcome is a surrogate. It may be a biochemical marker, for instance, the blood sugar level. And we are not clear that the blood sugar level actually is a good predictor of long-term patient-important outcomes like myocardial infarction or stroke and so on. But again, with a surrogate outcome, you can argue for the efficacy, but you could have clear clinical harm occurring during the treatment. And another consideration that occurs nowadays is that we have several treatments. Often there are many treatments available for the same disease condition, and the drugs are all similarly efficacious, but there's a need to work out which ones of the treatments are less harmful than the other ones. And there's been some debate recently, even in PLOS medicine, that some non-steroidal anti-inflammatory drugs, such as diclofenac, are more harmful than other drugs, such as ibuprofen. Yet, diclofenac is still very widely used in the population. So there's a need to decide if any of the agents are safer than the other ones. Now, what errors may arise in judging treatment effect? So I think all of you have heard of a type 1 error, which I feel is like a false positive error. And this is where you make an error in finding an effect. So you found a significant difference between the groups when actually there was no true effect. And this bias all of you are familiar with. What I like to draw attention to is the type 2 error, which is like a false negative. And I'm more concerned about type 2 errors when assessing harms, because you missed the possibility of harm from the intervention when you concluded that there was no difference found between the groups. So type 2 error is worrying in assessing harms, because you may end up concluding that the treatment was safe. Now, how do you avoid some of these errors? Well, most of us are familiar with randomized controlled trials, where there's a primary outcome of benefit, and the trialists do a power calculation. This enables appropriate sample size to be used to detect the important difference. So there are sufficient number of participants for you to be able to detect a significant difference between the groups. And therefore, an adequately powered trial means that the type 2 error is less likely. So effectively, by powering the study, you are unlikely to miss a significant difference. Instead, when we're looking at trials, we often spend our time assessing for type 1 error, which is wrongly finding a significant difference. So most tools that you're familiar with focus on biases behind type 1 errors. And there's little discussion of type 2 errors. So a lot of what I'm going to talk about in this session today is to do with type 2 errors. And I believe that type 2 error, which is missing the finding of significant harm, is the key issue with study of adverse effects. And this arises from two reasons. One is that many adverse effects, there's only a small relative risk increase due to the intervention. So it's difficult to detect the exact harm. Secondly, most serious rare adverse events have a low background incidence. So it's very hard sometimes in smaller sample size studies to actually detect any adverse effects. So the trial is powered to detect significant benefit, but it's never sufficiently powered to detect significant harm. And often the intervention is therefore interpreted as being safe and effective. Safe because no significant harm was found, and effective because the power calculation enabled a significant benefit to be detected. So this leads to this erroneous conclusions in judging the benefit-harm balance. So in one example, this was published in the New England Journal of Medicine a few months ago. This studied aspirin versus placebo in patients who had venous thromboembolism, which is pulmonary embolism or deep venous thrombosis. There's a priorized sample size calculation. based on a 7% rate of recurrent venous thromboembolism events. So that's the primary efficacy outcome, which is powered on. And right in the abstract, I saw this. It said, no significant difference in bleeding episodes, rate of 0.6% per year with placebo versus 1.1% per year with aspirin. P equals 0.02. So by putting the P equals 0.02 there, the authors are saying there was no significant harm from bleeding episodes due to the aspirin. But actually, when you read into the paper itself, in a table, it says that the hazard ratio for bleeding events was actually 1.73. So there was actually an elevated risk of bleeding, but it was non-statistically significant because the rate of the bleeding adverse event was so low at 0.6% per year with placebo that the study wasn't powered to detect a significant risk of hemorrhage with aspirin. So this is one example where no significant harm was detected simply because the power calculation was not geared towards recruiting sufficient patients for this study. And this is a commonplace problem that there are at least 3 new oral anticoagulants being launched in the market now, and bleeding is a major concern with them. But again, similar to the aspirin example that I've pointed out, the studies are powered on high rates of venous thromboembolism. And although significant benefit is relatively easy to detect based on that power, none of the studies are able to identify significant harm. The trials use different definitions of bleeding. So there was major bleeding, there was severe bleeding, and there was clinically relevant bleeding. And because of all the different definitions being used, it is currently impossible to make robust judgments when choosing which one of these drugs represents a safer option. So we have 3 available drugs, and we are unable to make a choice between them as to which one is safer. And that's because there's insufficient sample size and poor reporting. Okay, so we're focusing on the issue of risk of bias in studies, and you will be familiar with a risk of bias tool that then in situations where a significant difference was found between the groups. So this is a typical scenario in an adequately powered RCT where the interpretation is that the intervention was significantly more beneficial than the placebo or the control arm. And your risk of bias tool looks at, are there any alternative explanations for this significant benefit other than the effect of the intervention? And so you have items on the risk of bias tool which says which items could have caused the difference between groups. So perhaps the participants were not properly randomized, and there were confounders that could have led to the observed difference. There was a lack of blinding, so this led to a difference being observed when it actually was not true. And obviously other issues like attrition and selective reporting of outcomes. And I think most of you are familiar with these established tools for this type of bias where a significant difference was found between groups, and you want to be sure that there is a genuine difference. So why do we use this sort of tools for bias? Well, you would like to protect patients from false claims of benefit or efficacy. You need not divert resources towards the intervention if it was bias that caused you to find a significant benefit. And equally, you do not wish to wrongly declare that the intervention is significantly harmful. So all of you are familiar with assessing bias in situations where there is an observed or significant difference between the groups. Well, what about the situation with adverse effects when you commonly read that there was no difference between the groups? So with adverse effects, the authors report no significant harm or no difference in adverse effect rates between groups. Some of you have looked at etiological data, so does using mobile phones cause brain cancer? And a similar situation would be that the study concludes that there was no association between the risk factor and the adverse outcome. So here, null findings are often interpreted at face value. We are happy to say there's no difference between groups. The intervention is safe and well tolerated, or there's no risk from it. No. So as part of today's questions, I'm going to raise the issue again. Is this statement of no difference or no significant harm, how valid is that interpretation? What about the possibility of a type 2 error where we missed the harm, or we missed out on finding a significant problem? So what does no significant harm imply when you're reading a study or you're reading a systematic review that makes that statement? Now, most of us judge this as no evidence of harm. And to clinicians, this is reassuring. That means we can safely use the treatment without any danger. And it seems to me that statements of no significant harm are not challenged as rigorously as those of significant benefit. Is there a threat or bias in this situation? And that brings us to the title of this talk. If nothing happened, is everything all right? Are we certain that the treatment is safe and does not convey any harm? So, is there any possibility of bias when we're assessing harm? So, if we define bias as any systematic deviation from the true value, well, typically in assessing benefit, the bias tends towards demonstrating efficacy of the intervention. So this is, in some ways, some people call this optimism bias, where we're all optimists. We like the new treatment to work so that we can cure the disease. What about adverse effects? Is the bias in the same way? And it may be true. There are optimists who use methods that show that the treatment is safe, there's low risk or no risk from the intervention, and the methods are used to generate wide 95% confidence intervals or p-values that don't reach significance. So optimists might like to try and play down the risk of harm from the intervention. Pessimists, on the other hand, who are worried about the interventions, will try their hardest to detect harm, or use methods that enable us to detect harm as reliably as possible. So I'm just going to look at the optimist viewpoint for most of this talk. And this is how to avoid finding harm if you're an optimist. Most often, these are errors of omission. For example, didn't measure it or didn't follow the patient up long enough, rather than deliberate steps to create bias. So it's harder to detect these errors of omission. You need very clear and transparent reporting of the methods to be able to identify situations where the researchers have not looked hard enough, they have not looked thoroughly enough to find evidence of harm. And this can take place at study level, perhaps in the trial itself, or this can take place at systematic review level, where the reviewers haven't looked very thoroughly for harm, and yet they may have concluded that the intervention is safe. So, what are the ways that we can make rare adverse events disappear from the study or from the systematic review? Well, this is one of the dangers which I warn you against. First of all, what are the participants in the studies? Are they healthy participants or they are true life patients? Because we know that lots of studies exclude patients that are at risk of adverse effects. And this is often written in the protocol itself. You can see it in the method section. We excluded patients who are have a poor life expectancy, those who are elderly, those who have poor renal function, and so on. The other issue which I've already mentioned is that the study doesn't measure the events or it limits the measure. Some trials only report on harms that are expected or judged related to the intervention. So some adverse events are discarded because they were judged not relevant. I'll talk a bit about lumping and splitting later, because that can be used to disguise signals of harm. There are statistical methods with low power, which I'll briefly touch on. And a lot of the time for rare events, there's a lot of focus on statistical significance rather than the boundaries or the 95% confidence intervals. And I think I like to emphasize, always look at the 95% confidence intervals. So, to summarize on this slide, what are the factors that reduce our chances of detecting harm? Well, the first bit is selection of study or selection of patients. So if you were a systematic reviewer and you did a narrow search and you only found short-term RCTs in small numbers of patients, then it's unlikely that you will be able to draw any meaningful conclusions on the presence or absence of harm. What about assessment of outcomes? And I'll show you examples later where coding or adverse events in trials makes it impossible to detect the adverse events. Lumping and splitting, which I'll discuss in a minute. And obviously selective reporting. I think many of you who have read trial reports will find that it's completely haphazard what is written in the trial report. Some of them report common events, some of them report serious events, some of them report events that occur in more than 3% of patients, so it's completely haphazard. In the analysis itself, how do the authors handle zero events, and do they use a random effects model? Because that is a low power model. It's unlikely to be able to detect it's unable to analyze rare events in a powerful manner if you use random effects. And finally, I'll talk about interpretation at the end. So, why is such strategy and choice of data source important in assessing adverse effects? Well, the main problem is that we are often dealing with sparse data. These are rare adverse events, and the pooled estimates can be markedly affected by missing data. So in a situation where you have very sparse data, one or two additional events can be sufficient to put your relative risk over the threshold of P 0.05. So even one or two events could make your estimates more precise, and they shrink 95% confidence intervals, which is very helpful with rare harms. Our overview found no systematic difference between published and unpublished data, e.g. The use of regulatory data can be very helpful in shrinking the 95% confidence intervals. And therefore, our recommendation is that we should use as wide a data source as possible, due to the fact that one or two events can make a huge difference. Now, is there any guidance on choice of data source? So we have made a classification on this slide, and one of the things at the top is the time course of the adverse event. If it occurs after short exposure or soon after exposure, the background incidence is common, and there's a reasonably large relative risk increase with the intervention, then RCTs, whether large or small, are likely to be able to yield useful information on this adverse effect. So something that occurs with short exposure, relatively large increase, fairly common in the population, then the RCT should be able to identify that. Or if it's a little bit less common than we thought, then you could do meta-analysis of RCTs. So this type of adverse effect can be seen in RCTs typically. This slide shows a completely different type of adverse effect. These are rare adverse effects. I've put rare as the incidence, and it only occurs after long-term exposure or a long period of use of the intervention. And if there's a reasonably large relative risk increase, which I show with two arrows, then perhaps non-randomized studies could detect this type of adverse effect, or you need meta-analysis of large long-term RCTs. So rare adverse events occurs after a long period exposure. You probably going to end up with non-randomized studies or some sort of meta-analysis of large RCTs or meta-analysis of non-randomized studies. So the conclusion from these two slides is that depending on the adverse effect of interest, you will try and identify studies that are able to measure this adverse effect in a somewhat reliable manner. So choice of data source is very important. Now, what is the effect of study selection, as in the examples I gave earlier? So what I'm saying is that for rare long-term harms, the initial short-term trials may give you misleading information. So we looked at the class of drugs known as thiazolidinediones and fractures. And the earlier trials, less than 12 months duration, when we pulled the data from 4 RCTs, if you look at the odds ratio, is 0.41 with wide 95% confidence intervals. But effectively, this says there's no evidence of significant harm in the short-term RCTs. And these were the earliest RCTs done for the drugs. A few years later, after the drugs had been on the market for some time, the later trials that were of longer duration, 18 months to 4 years, there were 6 RCTs. When we put the data in a meta-analysis, the odds ratio was significantly elevated at 1.51. So this illustrates the danger of looking at short-term early trials at the beginning where no harm was found, but when you look at long-term studies, then a significant fracture risk was identified. And as I mentioned earlier, if you're looking for long-term rare harms, then observational non-randomized studies, like a case control study, which I mentioned here, the fracture association was significantly detected with patients who had more than 8 prescriptions, about 13 to 15 months of drug use to detect the harm. So moral of the story is beware of short-term RCTs if you are interested in long-term harms. So are there any biases that can occur when we're looking at the adverse effect and the outcome selection? And yes, there's some dangers here where the trialists only report adverse events after a certain limited length of follow-up. So very important to assess how long the follow-up was and whether they reported on all events, or if the trialists had restricted their analysis to on-treatment events, or those judged related to treatment only. So there's some censoring going on here, which makes me worried when I read the trial report. So I accept that length of follow-up may not always be the issue, and it's fine if you're interested in events that occur in close temporal relationship to the intervention, but it's problematic if you're interested in long-term harm or you're interested in irreversible effects, because some of the harm may take place many months after the treatment has been stopped. And if the trialist censored that out, then you're going to miss the harm. Now, coding of events is very difficult, and I put a reference here to a systematic review that's looked at challenges in coding adverse events. This is a major problem for systematic reviewers. This is because the same events can be reported in several different ways, and I'll shortly show you an example. Even within individual studies, diverse terms can be used to describe similar events. Now, if there are many different terms used to report on similar events, this makes it very difficult to compare rates between trials or to pool the events. If you have meta-analysis, it becomes almost impossible if all the events are reported differently. So this creates a bias towards the null. Bias towards the null, as I said at the beginning, makes it impossible for you to detect a significant difference. And the next slide, I'll show you an example of what we struggled with when we were looking for ischemic cardiac events from rosiglitazone. So I've taken this straight from the GSK Clinical Trials Register, which provides public access to their trial data. And we were interested in myocardial ischemic events. And as you will see from this list, there are so many different events that could have been classified as myocardial infarction. So the top one is myocardial infarction, and it looks like rosiglitazone, RSG, has a greater rate than metformin, which was the control arm. But if you look at acute myocardial infarction, then it's 3 and 3 in each arm, so no difference between the arms. Myocardial ischemia, again, no difference between rosiglitazone and the control arm. And if you were analyzing acute coronary syndrome, which to me is a set of myocardial infarctions, then rosiglitazone is safer than metformin. So as a systematic reviewer, this creates lots of problems for you deciding which events to analyze. So this is a source of bias. Obviously, depending if you wanted to find favorable data or unfavorable data, you could have chosen an outcome that gives you a different risk ratio at the end. So very difficult to analyze such data. What about the validity of coding itself? Interestingly, there's one study that took a sample of 260 adverse events from a clinical trial. There were 2 coders at work. Both were trained, had several years experience, and independent blind coding was carried out, and discrepancies were checked. And they found that 12% of events were assigned different terms. So in the previous example, was it a myocardial infarction? Was it acute coronary syndrome? So different terms are assigned by different coders. A medical expert looked at the coding and in fact judged 12.5% of all coding as inaccurate. So although you might argue that miscoding affects trial arms equally and there's no differential influence, the wide distribution of the terms used, as I've shown, creates small numbers under each category and makes it difficult to pull the data when you're doing your meta-analysis. So coding is a big issue and a problem. Now I promised to talk about lumping and splitting. So what is lumping? Well, lumping can take place when you lump adverse effects together. So for instance, if you were looking at treatments in rheumatoid arthritis, you could add up all the adverse effects together. So I've marked in one of the rows total adverse effects, and in this case, the active drug had significantly fewer adverse effects, total adverse effects, than the placebo arm, and you could conclude that placebo was significantly more harmful than the intervention. But there is a danger in lumping all adverse effects together. This is because when you look at the breakdown of the adverse effects, you might find that joint pain, stiffness, and difficulty walking adverse events were much fewer with the active drug than as compared to placebo. So effectively, what was being measured in the total adverse effects was events that were closely related to the disease itself, which in this case was rheumatoid arthritis. So the drug actually made the arthritis better, and so there were fewer adverse events from joint pain and stiffness. And when you look at the other adverse effects, which were unrelated to the disease, you found that there was an increase with the drug and no increase with placebo. So lumping all the adverse effects together may disguise variations within the adverse effects rate. So I would advise you to be very cautious in lumping together all adverse effects, because it may disguise differences that occurred between the drug and the placebo. How about splitting? What do I mean by splitting? So we did this review where we looked at risk of pneumonia with steroids. And we know that steroids are immunosuppressant. They may increase the risk of infection. So the top row shows risk of any pneumonia adverse event. There are 1,038 events, and there's a significant risk with the steroid, odds ratio of 1.6 as compared to control. When you cut down the events to serious adverse events of pneumonia, So this is patients requiring hospitalization or they died from the event. Far fewer events. It's still significant at 1.71. When you chop it down further to pneumonia as a fatal adverse event, there are only 71 events. The odds ratio is 1.27, and you look at the 95% confidence intervals, it is not statistically significant. So you could end up writing in the abstract that there was no evidence of a significant increase in death from pneumonia from the intervention, which I think is a type 2 error, because there were too few events, only 71 events, broad confidence intervals with the upper limit of 2.03. It's not safe to conclude that there's no risk of harm based on this wide confidence intervals. So splitting can make significant harm disappear because you reduced it to very few events, and so there's loss of power. Okay, there are a number of other statistical controversies. For instance, how do we handle 0 events? And this is a very contentious point. So if you look at the two subheadings here, placebo there's 0 over 600, and drug is 0 over 600. And you add everything up together, 3 over 775 as compared to 6 over 775. So in such instances, the trial report will say that the risk of adverse events was very low and no difference between groups. If you only looked at the ones with well, 1 over 50 plus 2 over 50, that's 3 over 100 versus 6 over 100, then you might feel that the rates were not so low. So handling 0 events is a very debatable topic, and there's no consensus on that at the moment. The other trick that can be used to hide adverse events is to use a low power method. Risk difference meta-analysis, random effects meta-analysis have low power, and they're less likely to use significant estimates. So this leads to type 2 error. Where possible, the Cochrane recommended model for meta-analysis is to use a Pareto odds ratio as the proposed method. It has the greatest power to detect rare events. Okay, so that's a little bit of statistical complexity. But what about interpretation of adverse effects data? And I often read the discussion section of the trials, and I get really worried. I think it's fair enough. There's no evidence of manipulation of data in industry-funded studies, for example. But we found that the funding source could influence the interpretation and the discussion, where the interpretation and conclusion was that the drug was safe, even when you looked at the results section in studies that found a statistically significant increase in adverse effects for the sponsors' products. So beware of interpretations that the drug is safe, even when they have a table that shows significant harm. Interpretation is sometimes doubtful. Certainly, the German IQWiG agency found that for reboxetine and an antidepressant drug, that the sponsors' unpublished data actually showed limited or poor efficacy, but a significantly increased harm. So it's very important to try and find the actual raw data from the sponsor or trial registries or regulatory data if possible. Now, I mentioned that interpretation can be a minefield and it's difficult, and I've just put some examples here of statements that you will find in the abstracts or in the discussion sections. So as a systematic reviewer, you should be very cautious when you're faced with this statement, for example. In this current study, mortality in the placebo arm was unusually low. So when you look at the results, there was a much higher rate of deaths in the intervention arm as compared to the placebo arm. But the authors of this trial preferred to say that the mortality with placebo was low, rather than saying that the drug increased mortality. So this was a double-blind, placebo-controlled, randomized RCT. So there's no reason for any difference in the mortality in the placebo arm, except for the effect of the intervention. So I was quite worried to see that sort of statement. But the next example is equally worrying. There were 3 atrial fibrillation adverse events with the drug versus none with placebo. But 2 of these events were considered unrelated to treatment. So the authors dismissed 2 of the 3 atrial fibrillation events with the drug by saying they were unrelated, which I think it's difficult to justify this sort of statement. And I don't want to be an industry basher, because we see the same findings in government-sponsored trials, where this example said that the proportion of adverse effects was higher with the treatment arm, but most of the excess events have not been associated previously with systemic therapy. So they dismissed the adverse events by saying hasn't been previously seen before. So probably it may not be important. So be careful when you read abstracts and results section. So having warned you of all of the dangers, particularly in looking for type 2 error, are there any methods of detecting bias in reporting of adverse effects? Well, one of the validated tools that I like to recommend is something called McHarm. This is developed at McMaster University, and I'm sorry to put a picture of a burger up there, because McHarm always reminds me of going to a dodgy burger joint and feeling quite ill after eating their burgers. And you can find the tool. I've given a link on the slides. So if you type in McHarm in Google, for example, it should be able to take you to the right place. This is a multi-component scale, and you can select relevant ones from the scale. I've given some examples in the next slide here. So key components I'm interested in to use from McHarm are, for instance, definition of the expected adverse event. Were the harms predefined using precise definitions? Were serious events precisely defined? Which methods were used to collect the adverse effects data? For instance, did the study specify the timing and frequency of collection of harms? And the reason I'm really interested in this is that I often worry that the trial investigators didn't measure harm very often. Maybe they did a blood test once every 6 months or once a year, so perhaps they couldn't have picked up any adverse events with that sort of measurement. So I'm really interested in finding out how often were the harms measured, and who did the measurement. Was it well defined? Okay, so we've covered some idea of how to assess the risk of bias and what to look out for. There are some insurmountable problems that we may not be able to resolve. We appreciate that randomized controlled trial reports emphasize benefit. Adverse effects are usually secondary or tertiary outcomes, so they're often not pre-specified, they're not well defined, the method of monitoring is not described, and there's little space and few details available. And I'm sure there's tons of selective reporting going on. And obviously, unlike a single primary beneficial outcome, there's a huge range of potential adverse effects. So there's lots of reporting in different formats, and you can't compare the data. Okay, so is there any progress on this front? Well, interestingly enough, industry had a meeting with their medical writers, and they accepted in this consensus that terms such as no clinically significant adverse events and no unexpected adverse events are common. Such phrases lack clinical relevance. So those of you who are authors of systematic reviews, I think we should avoid writing this sort of sentence, because it's really hard to judge whether it's true or not. And indeed, the industry consensus was that in studies that are not powered to assess rare adverse events, it is more appropriate to qualify the findings, e.g., additional severe adverse events were not detected in this short, small trial. So this points out the limitations of the trial data, and that we should avoid making broad statements. I think this is important for all of us who who do systematic reviews where we discuss whether there was any harm or not. So, is there any other progress that we can make from this? Well, recently the BMJ has said that they want the full trial data set to be available for public scrutiny, and I think that's great. But we've had more than 10 years of failed efforts for transparent and detailed reporting of adverse effects in journals. And my argument currently is that there's no incentives for those parties who hold the data. This is because the current vague reporting makes harm less readily identifiable and makes it more difficult for us to compare between drugs, which is fine for certain parties. It's better for certain parties that we can't compare harm easily. And indeed, the regulators and pharma industry have full access to the data. It's not necessary for the public and academics to look at the data. Regulators and the are the ones who know best. So I think we will continue to have problems getting all the relevant data for our systematic reviews and meta-analysis. So what are the key messages from this session? Well, I hope I've identified numerous ways in which trials or systematic reviews can be shaped or influenced to show or hide harm, and that's very important to explicitly look at the methods that were used in measuring harm, and to try and pick up the results from unpublished data, regulatory authority websites, and company trial data sets. Beware of selective reporting and missing data, and I've shown you 3 examples of what I would call unreliable interpretation of the data. So please look at the data yourself and don't trust the interpretation that's given in the report. And the key things to avoid false reassurances, to avoid making false conclusions on safety, I suggest that you look at the choice of appropriate data source, appropriate participants with sufficient follow-up to measure the adverse events of interest, what methods were used in measuring the harms, how broad the 95% confidence intervals are, and how the data was put together, what methods were used. And so that's my final slide. I note that some of you have commented that you've had trouble finding the link to the McHarm. So I suggest that you can just type in McHarm into Google if you have difficulty with accessing the link to the McHarm scale, which is the one that I usually recommend to systematic reviewers who wish to check the validity of adverse effects data. So I'm pleased to take any other questions.
Thank you so much for your presentation today, Yoon. Can everybody please send through a round of applause? We really appreciate you taking the time to present today. And for anybody who had trouble, who missed anything, we will be circulating the slides. They will come around via email, probably tomorrow. We will also be sending through a link to the evaluation form. You'll find a link to the evaluation form currently in the chat room, and if you could please take a few moments to answer that, we'd really appreciate you taking the time. And Yoon will be staying on to answer any questions that you have. Yoon, there are a couple that already came through from Titania who asked your opinion about risk differences in cases of sparse data. So if you could take a look at the chat room and respond to that, I'd appreciate it.
Yeah, so we had a question about using arc-sign transform risk differences in case of sparse data and zero events. No, I absolutely agree. The absolute risk differences models are clinically useful for making judgments and calculating a number needed to harm. Typically, the method I've used so far is to use the p-odds ratio as the main model, and then I apply the p-odds ratio to a defined adverse event rate to calculate the NNT for harm. So that's the model I've been using rather than the risk difference. There's some additional questions from Tatiana about post hoc power calculations to detect type 2 error. Again, if you're able to do that, then you could reliably comment and say that based on the event rate that's been found in the trial, that there was only a certain % chance of finding detecting this harm. So if you're able to do that, that's helpful. And finally, the question about there's a question about different algorithms for ranking or strengths of evidence about benefits and harms. At the moment, I don't make a specific recommendation on particular algorithms, but there is a big Cochrane risk or bias meeting taking place in Oxford in a couple of weeks' time, and we should have more clarity on that in future. Okay, so there are other questions about access to data and the extent of unpublished data. So what do we do in a situation? Nowadays, I've started producing flow charts which show how many trials that I felt were likely to have relevant data, but I was unable to access the data. And I write down in my review how many patients were involved in those trials. That gives the readers some idea of how much missing data there is as compared to the actual number of participants we were able to include in the review. So I've been much more explicit in documenting the size of the missing data. Great, and I think some of you still struggling with finding the McHam scale. We'll do our best to track it down yet again. Some of you have been successful going through the Bias Methods Group website.
So thank you very much, everybody, for your time, for joining us today. To let you know, this recording will be available online on the Canadian Cochrane Centre's webpage in about a month's time. Maybe earlier, but within a month, you can check online and find a recording of today's session. And again, we'll be circulating a copy of the slides to everybody who registered via our website. So thank you so much, Yoon. I really appreciate your time today, and thank you so much for everybody for attending our webinars. We have one more webinar coming up in March 21st. Al Mayhew will be presenting on non-randomized studies in EPOCH reviews from the Effective Practice and Organization of Care Group. So thank you so much. I hope to see you there, and thank you very much, Yoon.